Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. NIK NIKAM. This is a continuation of cardiology lectures. Today, we are going to be talking about cardiology test ordering strategies. What kind of test do we order and why do we order it? What are we looking for? And what are we going to do with the information that we get once the tests are done? So let us jump right into the feature presentation. As I said, the presentation is on cardiology test ordering strategies. We're going to start off with a very simple test. First of all, before we do any kind of test, we need to find out some of these important points. So we're going to use stress tests for evaluation of chest pain in a patient for inducible myocardial ischemia. Before we proceed any further, after we have taken the history and physical examination, we need to decide, is this the right test for this particular patient? In a broader context, if you do a stress test, is that the right appropriate test? The second question we need to answer is, what are we expecting the stress test to show? We expect it to be normal, we expect it to be abnormal, we expect it to be indeterminate. So we need to be prepared for what we are going to do with the results that we get from the stress test, because not all tests are going to give you a perfect answer. There's no such thing as a perfect answer or a perfect test. So we need to be prepared to see how we're going to deal with the information that we get from the stress test. And the next question is, how likely is this stress test going to give us the result we are looking for? If we think this patient has coronary artery disease and we expect the stress test to be positive, how can we predict that the stress test is a very reliable test in this particular patient to determine any evidence of myocardial ischemia? Keeping that in mind, when we are evaluating a patient, first of all, we need to know, before we order the patient tests, what is the patient condition? What was the presentation? What were the clinical findings? What were the preliminary lab tests? What do they indicate? So if a candidate, if it's a young person, who is the candidate? What are the risk factors? And all these things we need to be taken into consideration so we can appropriately choose a given test for a given individual. For example, let's take a scenario of a 20-year-old medical student, first year, before final exam, comes to the ER with chest pain. 1 week before the exam, it's not a good time to be there. Okay, his physical exam is normal, vital signs are normal, lab tests are okay, EKG looks normal. I don't know how I got this $750, but let's ignore that one. Anyway, so all these exams look okay. The question is, what kind of tests are we going to order for this person? Does he need a stress test to begin with? The physical exam is normal, vital signs are normal, the blood tests are normal, and the EKG is normal. So what are you going to do? And of course, this is 1 week before the exam, and if he has a family history of heart disease, then we need to be concerned about it. So there are a variety of choices available to look for any evidence of the presence of coronary artery disease, the extent of the coronary artery disease, the extent of myocardial ischemia, the amount of myocardial damage, and the left ventricular function. And in this example of a 20-year-old person, what are we basically looking for? We are not looking for ejection fraction. We are not looking for the amount of myocardial damage. We are not looking for the extent of coronary artery disease. Our first question is, does he have coronary artery disease or not? And we have to see which test will answer that question in the simplest, least expensive way. So let's look at this. If you do a regular treadmill, it's going to cost you about $150. If you combine that with echocardiography, it may cost you if you combine with echocardiography, it may cost you $750. If you use a nuclear PET scan, it may cost you almost $1,500. Nuclear scan, that is the using a radioisotope, or if you use a PET scan with the CT scan combined, then you're talking about $3,000. Do you want to subject him to nuclear scan or a PET scan? That's the decision we have to be making. What is the most appropriate test that we need to do for a given person? In this person, maybe you could just reassure him and send him and say, if you get chest pain again, come back, we will do a regular treadmill test and see how you perform, especially if the pain had resolved. But sometimes they could have pericarditis and they may have persistent pain, and that's something that would have shown up on the electrocardiogram or some blood tests. That's why putting the whole clinical context is so important to decide what tests we use and what results we are looking for. Okay, so as we said, maybe at the most, if he is really concerned, anxious, we can do a stress test, and if it's normal, you can say reassure him and tell him to go and study harder. Whereas if you're dealing with a different type of person, then it changes. Let's take a 65-year-old patient with history of diabetes, coronary artery disease, 3 stents in the past, heart failure, ejection fraction 40%, 1 week of vague chest pain, presents to the hospital, pulse 100, irregular, pay attention, every word is very important here. That means he could have atrial fibrillation or arrhythmias. Occasional rouse, so that is sort of consistent with the history of heart failure. Maybe his heart failure might have gotten worse. Lab troponins are not okay. Actually, the troponins are sort of at the upper limit of normal. All right. And of course, the EKG is not going to help you because with the history of heart failure and coronary artery disease, this person has left ventricular hypertrophy with the STT changes. Now, what tests are you going to use to find out this person's chest pain, which has been lingering on for almost a week? So it is not an acute myocardial infarction. Otherwise, it would have shown up in the enzymes and EKGs. So what are we going to use? A regular treadmill test? No, that's not going to help you. However, can we use an echocardiography with a stress test? That depends upon this person's ability to exercise. Unless this person reaches 85% of the predicted maximum heart rate, then the echocardiography may not be useful. And if the person is obese and doesn't have good echo windows, again, echocardiography may not be useful. And the third point is, since this patient has a heart rate of 100 already with irregular heart rhythm, and if he does or she does have atrial fibrillation, using a dobutamine stress echocardiography may not be the right choice because it may just kick their heart rate up too much, where it may be not meaningful. So all these things we have to take into consideration. A nuclear PET scan would be a good option for this person because if he has arthritis and he can't exercise, this is a test which can be easily performed using a chemical stress test. We can look for the myocardial perfusion, regional perfusion defects or scars, left ventricular size, left ventricular thickness, left ventricular volume, ejection fraction, and wall motion abnormalities. So we get a whole host of information and compare this with the previous test this person had and see if this is something new. If the person has reversible ischemia, how much is the reversible ischemia? If it's like a 5% reversible ischemia, you're not going to make a big difference. This patient can as well be treated with medical treatment versus coronary intervention. So that is how we decide what test needs to be done, what are we looking for the results, and when we get the results, how are we going to apply that to make the next clinical decision. If this person had 5% defect, I would just continue with the medications, optimize the heart failure, get the weight reduction, get the patient to lose weight, control diabetes, and so a medical management is appropriate. Whereas if he has a 25% perfusion defect in the anterior wall with a nuclear stress test, I would say let's go for coronary angiography and coronary intervention if it is necessary. A PET scan is much more useful, and I think it's useful especially in patients with questionable perfusion defects, whether it is hibernating myocardium or viable myocardium or dead scar, and that may be useful in patients with severe heart failure or those who are going for transplant or LVAD, something like that. So this gives you a very quick synopsis of how we strategize using tests in cardiac patients so that we get the maximum benefit out of any test we do and how we can use that information to make the next clinical decision. I'm Dr. NIK NIKAM. Thank you so much for watching, and we have more than 200 cardiology lectures on our cardiology lecture series playlist. Please do watch them, and I will see you in the next video.